Thank you. That sounded like Professor Achenbach's credentials. I'd love to take that, but perhaps maybe give me 20 years. So I'm a structural interventional cardiologist in Munich, but maybe one day. Thank you, Brian. Thank you very much. Okay, I'll talk through this talk fairly quickly, just for the interest of time. I'm talking about cracking the ring in small valves. We know that valve-in-valve therapy has become very suitable for TAVI. It's comparable outcomes to redo surgery. The problem in small valves is the radius of the device that's been placed. Resistance increases a lot, and if you then place a TAVI inside that, you end up with high gradients. When you're looking at a surgical valve, they are always numbered by the size. So, for example, if you have a Paramount 21, this is based on the label size. However, the inner diameter of the prosthesis will be considerably smaller than that. And this is why we get such problems with the gradients. The issue as well with these valves is we can't put in a big transcatheter heart valve because the ring prevents us from placing a larger device. It's non-distensible. This is just showing why it's important to have a well-expanded THV. This is the balloon expandable sapien valve. If you don't expand it properly, as shown at the bottom, then the leaflets don't open up properly. You end up with increased stress on the valve, and this may lead to degradation over time. So this is not an evil ring that we have to deal with as cardiologists, but rather we are stuck with these small biosurgical prostheses. Less than 21 are the ones that can really cause problems. It's very important when you're assessing these patients that you decide whether the high gradient that they're now presenting with is new or old. So if you have a new increase in gradient, then the chances are that you can improve this are much higher. If the gradient has been high since surgery, then you are probably not going to be able to improve this because there was patient prosthesis mismatch in the first place. What strategies do we currently have? We know from in vitro studies that if you place a balloon expandable valve higher up, you end up with lower gradients. But then there's also a risk that this valve can embolize more easily. There is some evidence that using a supraannular valve, where the leaflets are sitting above the actual sewing ring of the implanted bioprosthesis, is also a better option. But there may be some reasons why you prefer to use a balloon expandable valve instead of a self-expanding. Now, of course, this technique of cracking the ring has been performed by the pediatric cardiologists. This is a paper from a professor at our institute who was using this technique back in 2014 for patients who'd undergone congenital repair, and they were then able to put in much larger transcatheter heart valves, a Melody heart valve, and the S3 valve as well, on the pulmonary side. So it's only recently that this technique has been brought over to the aortic position. One paper here talking about in vitro, demonstrating which valves can be cracked, and then an in vivo paper with 20 cases looking at the feasibility in actual patients. So here we see a technique shown in vitro, cracking the ring on the left side either with a single balloon or with a double balloon, going to very high pressures. I'll just show you this video quickly if it will play. So the balloon is being inflated, and at 9 atmospheres you see a little pop, and the sewing ring of the valve has been broken. However, the fabric Dacron sheath around the outside remains intact. So the valve doesn't collapse or fall apart, but you are then able to put in a larger device if that's your strategy. This is just showing the fracture of the plastic ring. And just to be aware that the balloon burst rated pressure was exceeded in all cases using this technique. So these are the two balloons that were published in use, a true dilatation balloon, Atlas Gold. This was showing which valves could be broken. So in this case, there were some that were not able to actually be cracked, and the reason for that was because of a metal sewing ring. So at the moment that seems to be a limitation. If this technique is to be used, we have to be careful not to try and use it in these ones with metal rings. So looking at the in vivo data, again, this is a small series coming from the US. They performed balloon aortic valvuloplasty either before or after THV implantation. They did manage to get very good reduction in gradients from a mean of 20 to 7, and also an increase in the effective valve orifice area. They didn't report any complications in this cohort. Now, just to show what our experience has been in Munich, this year we've dealt with 6 patients that have had a valve size 21 or less. I'll just show you quickly what we've had. The case number 1 and number 2, if you look at the post-procedural mean gradients after implanting an S320 in these valves, we were really having quite disappointing results. So we were not pleased with seeing this. And around the time, in case number 3, for separate reasons, we actually took a core valve Evolut R, and in this case got an acceptable gradient afterwards. Case number 4 and number 5, I'd just like to talk through quickly. In the first case, we implanted an Evolut R23. The gradient was high after that, and I'll show you how we dealt with that. In case number 5, I'll show you a good case we had with an S320 inside a small valve using a high pressure post-dilatation. And in case number 6, although we thought we had a very good result in the cath lab with an invasive gradient of 13, there was some discrepancy with the echo afterwards. So here's the first case, 84-year-old lady, symptomatic with a mean gradient 58 across this valve. The inner diameter of this valve is 19 millimeters, bear in mind. So here's the core valve being implanted. This lady had a very, very low coronary height, so we wanted a valve that we could remove if we occluded the left main. This is finally the first shot after deployment. It's a pretty good result. We were quite happy with this. However, she had a 55 millimeter gradient on the echo. So that's a 2 millimeter improvement. We weren't very pleased with that. As you can see in the middle, the valve is clearly underexpanded inside the sewing ring. So we brought this lady back to the cath lab. Just a 3D showing that a bit more clearly. Post-dilated at high pressure. There was a sudden drop in pressure, and the valve certainly looks much better expanded. It has migrated upwards very slightly, but the functional result stays good. We had a good invasive gradient, and on CT afterwards, again, we showed a very good improvement in deployment of this valve. This was the second case. On the left side, you see implantation of an S320. We haven't attempted to high pressure pre-dilate this valve at the moment. We then post-dilated it at high pressure with a 20 millimeter true dilatation balloon, 16 atmospheres. We certainly get a better appearance expansion of the valve itself. We do get some increase in the internal diameter, the area that we measured on the valve. I think, to be honest, I'm not sure that we're aggressively treating our valves enough. It's very early experience for us in our center. These are just the first 3 cases we've used this high pressure technique on. So I think if we take perhaps slightly larger balloons in future cases, one of the reasons we didn't go more aggressively with these patients is they had small anatomy in the first place. So we weren't necessarily going to be comfortable with putting in a 23 millimeter device because we were worried about compressing and occluding the coronaries. This was the hemodynamic result here. Good result, 12 millimeters. So how do you determine success in this technique? During intraprocedural, you may get a sudden pressure drop as the sewing ring gives way. Of course, the differential for this is that you can get a balloon rupture. Now, with these balloons, because of the design, the rupture may not be very dramatic. We've certainly burst at least one of the true dilatation balloons, but it forms a tiny little hole and just leaks slowly. You may hear a popping sound. This was reported from the in vivo case. We haven't heard any pops in our cath lab yet. It sounds a little bit worrying. However, I'm assured by our pediatric cardiology colleagues that this is not too dramatic. Invasive hemodynamics is important. This has to be checked very carefully with 2 catheters. And of course, your intraprocedural or your post-procedural echo, depending on your institution's policy. So what problems might there be with this? Prolonged rapid pacing is an issue. You have to fully inflate a balloon, and then you have to block off your inflator and then go up to even higher pressure. There may be an increased stroke risk. We know post-dilatation is associated with stroke. Rupturing the balloon, dislodging the THV, annulus rupture. In theory, it's not too likely because the Dacron ring of the bioprosthesis still contains the balloon. Damaging the leaflets, this is a question if you're inflating with a valve that's in position, a THV that has just been placed. I think there are still some outstanding questions with this technique. What size balloon do we use? Do we use it based on the inner diameter, or do we use it, as they did in the study, the published study, based on the label size? When do we do this high pressure inflation? Before or after we implant our THV? That, I think, is a balance between inducing severe aortic regurgitation and damaging the leaflets of the THV. We have also seen a bit of discrepancy with measurements of the gradients. So to conclude, valve-in-valve for small bioprosthesis carries a high risk of a residual elevated gradient. This is a big problem for TAVI at the moment. The balloon expandable valves may be a little bit better in terms of reduced gradients, but they can still be associated with problems. And this ring fracture technique is a novel technique that we believe appears to be safe, allowing us to improve gradients after valve-in-valve, and maybe even implant larger valves as well. Thank you.